and I think in the recording I gave an example. We've all experienced this. Hopefully we've avoided a car accident, right? Have you all experienced, you put on the brakes and almost hit somebody and then your heart's going like this? You're having the short-term stress response, right? When you avoid that car accident. I think all of us have experienced that, right? Or maybe, hopefully not get in a car accident and your heart's beating and you're breathing faster. Because your Neanderthal brain thinks you're running from a bear, right? Thinks you're running from that bear. And that's your sympathetic nervous system, right? What's the rest and digest? Parasympathetic, right? So sympathetic is going to be epinephrine or norepinephrine. So what are some of the long-term issues? What if someone has long-term stress? Let's say they just got a really stressful situation in their life. Sometimes nursing school, unless you can't manage it, right? We got to be able to have our self-care, do our meditation, yoga, journaling, or whatever you do to de-stress, right? Exercise. What is the long-term hormones we might experience? Somebody over here, long-term hormones that's secreted. So it's just a C. Cortisol. Yeah, cortisol. Cortisol long-term will be secreted. Now, what does cortisol do to some of our body systems? What can it do? Increase what?
Blood glucose.
Yes, blood glucose. And what could that lead to long term? Type 2 diabetes. Yeah. Didn't you guys find that oh my gosh, like a little red flag there? You're like, oh, ooh, manage stress. My friend does this restorative yoga on Zoom, a friend of mine from Florida, and she does it every Sunday night. And I'm like, because it's supposed to restore, bring down your cortisol level. So I'm like, okay. And I can feel it when I do it. So anyways. To reduce your stress. So that was just a quick review. So if you haven't watched the video, please watch the PowerPoint review. So what we're going to do today is review chapter 7 with a little case study, just to help us review the concepts. So we've got Marge as a 42-year-old woman who works full-time as a legal secretary. So the big thing when you're going to see these case studies, not yet, but maybe you'll start seeing them more in your foundations class and maybe health assessment, maybe on your second and third exam. Because NCLEX, you're going to see at least 3 to 6 case studies on your NCLEX. And they're going to have about 6 questions attached to them. So the big thing you need to do is recognize clues. So we just talked about stress, right? So we have to recognize clues. So 42-year-old woman, and she's a legal secretary. Now, when NCLEX gives you gender or numbers, it's important. Because they could say a client. If the age and gender doesn't matter, it doesn't matter, it's NCLEX. So we have a 42-year-old woman who works as a legal secretary. She has 3 children, ages 6, 9, and 11 years. Do we have any clues about stress in this first sentence? Yes. She's got 3 kids, right? And she was divorced 6 months ago. Can we add that to her list? Yep. And relocated to a new school district. Yeah. There's another one, right? We're recognizing clues of stress. So this also means you're listening to your patients, right? You're listening to your patients. So her children are adjusting to school, but Marge has not established any friendships in the neighborhood. Doesn't that help kind of, you can go to your friend and go, blah, 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 and de-stress, right? You could de-stress with your friend. She's in the clinic today with severe migraine. What do we know about migraines and long-term stress? It can happen. It can happen, right? Because all that tension, right? And it's not responding to ibuprofen, so she's gone to the clinic. So let's look at this question. A nurse is assessing Marge, who came into urgent care due to experiencing severe migraine headaches. According to Seil's General Adaptation Syndrome, Marge is in what stage? So give me A, 1A, 2B, 3C, etc. So think about it and give me your... Okay. So let's see. It's actually exhaustion. Yeah, I saw some of you select that. This PowerPoint is available now. I opened it up at 8 o'clock. So I didn't want you to get the answers ahead of time. So she's in exhaustion, and so the stages are the alarm stage, and analogy did I give for the alarm stage when I was talking about swimming in the ocean, and maybe like the Atlantic or Pacific, because the Gulf of Mexico doesn't have really strong waves unless there's a hurricane. And you get, the alarm stage is when you get hit by the stress initially, whether it's getting a cold, having a car accident, broken bones, or your loved one says, I want to break up with you, or oh my gosh, I got to study for my exam. That stress hits you. So that's the alarm stage, and what I said was that you get knocked over by the waves, right? And then what is the resistance? What analogy did I use if our patients can adapt?
They kind of flow with the waves.
Yeah, you can swim with the waves or get a boogie board or a surfboard and surf with the waves, right? Whether they adapt or they don't adapt. Now, she attempted to adapt, didn't she?
Yeah.
And it's not working. So our job is to give them that surfboard, right? As nurses and healthcare providers, physicians, our healthcare team. So their surfboard might be meditation practice, migraine medications that are prescription that would be for the healthcare provider to provide, but we can recommend. So we can give our patients something to help them adapt, whether it's meditation practices or medications, lifestyle changes, diet, exercise, right? So what is the stage? So resistance, exhaustion. Because exhaustion, they can get what eventually, which she has? Some kind of illness. It manifests as to illness, whether migraines, diabetes type 2, hypertension, stuff like that. So it can manifest into an illness, or they die. Like I talked about, the analogy of exhaustion would be the patient drowns in the ocean, right? They drowned. So we don't want that to happen, and that's our goal as nurses, is to help our patients. So she is now in exhaustion, because now she's developed an illness, a headache, migraines. That makes sense? Some of you said resistance. Resistance might have been the ibuprofen was working. Okay, does that help? Now ibuprofen's not working, so she's gone past it, she's drowning.
Okay.
Yeah, does that help? Okay, good. Okay, now it's the same scenario. We haven't changed our scenario, but different question. The nurse knows that because stress or allostatic overload, what's allostatic versus homeostasis? What's the difference?
Homeostasis is the body maintains equilibrium, and allostasis.
Yeah, normal balance. You guys are just kind of, it's nice little stereos. It's here, it's good. So homeostasis is just our breathing, our calcium levels, everything's in balance, right? But then allostasis is what?
You get knocked out of balance, you have to come back to it.
Yeah, you get knocked out of balance, and it's your body trying to get back into balance. It's getting knocked over by that wave, and you're like, okay, am I going to drown, or am I going to body surf? Am I going to resist, or am I going to try to figure out a way to get through this, right? Because stress is going to happen. We just got to learn how to adapt to it. Coping mechanisms. Okay, so she's in allostatic overload, is believed to be a significant factor in the etiological progression of the migraine. It may be helpful to suggest that Marge, so give me your 1, 2, 3s, and 4s. Okay, yeah. So she needs to, the big thing, you're going to learn this in Foundations and Health Assessment. The big thing is helping our patients identify their stressors. Because if they can identify it, then we can move into, well, let's talk about how we can help you manage that stress, right? Okay, good. All right, so that's pretty much the key there, or so helping her identify what's going on. Oh, yeah, question. Oh, sorry, go ahead.
No, you're fine. So, could you explain why C wouldn't work?
Well, see, the thing is, you're going to learn more about this. So the big thing, have you ever heard about people who are, I'll give an example of alcoholics. They need to state, I'm an alcoholic and I need help. We can't say, you cannot drag an alcoholic to AA unless they want to go to Alcoholics Anonymous. So the big thing with your patients, you can sit there and give them a pamphlet. Here, this is what you can do to de-stress. Okay, they're going to throw it away. You need to it's something called therapeutic communication, and find out that her stressor may not be her kids. We think it might be her kids. Her stressor might be her work. You know, we need to find out what her stressor is. And then we can go from there. Does that help?
Yes, ma'am.
Okay, yeah. All right. Okay, good. So let's see, 42, I don't think anything's changed in the scenario. Okay, the nurse realizes that Marge does not think that her migraines are a result of stress because her sister is in such much worse life situation than she is and does not get migraines. Which statement by the nurse would be the best reply? I'm just giving some chance for people to ponder and read, because some people like to ponder a little bit more. Okay. So people respond to stress differently. Our genetics, our life experiences, resilience and grit, different things. So this is why we ask her. This is why we ask her, what is her stress? What does she think is her stress, right? So good. And there's the code. Perception of stress, physiological state, in history, all this kind of stuff, right? So it's going to be different for all patients. So same scenario, the nurse examines Marge and notices an elevated heart rate and blood pressure. The most likely explanation for these signs is? Things you make you go, It's actually those catecholamines. It's the catecholamines that increase the heart rate and blood pressure, increase respiratory rate, vasodilate. It's going to dilate your pupils because your Neanderthal brain thinks you're running from a bear, right? So you want to see, fight or flight. Am I going to hide from the bear or I'm going to fight the bear? So your pupils are dilated. So the glucocorticoids are going to increase. That's the long term. The long term is the glucocorticoids. The short term is the catecholamines. Just think about you avoided that car accident. And then everything kind of calms down after you pulled over and like took a deep breath. And I'm sure you've all felt that driving, right? That experience. So I'm trying to give something relatable, you know, and then your heart rate goes down. You're like, okay, I'm okay now, right? After that experience, that's short term. Short term. So long term, glucocorticoids, cortisol, same thing. Glucocorticoids, cortisol, same thing. Short-term catecholamines. And then there's the explanation. And again, this PowerPoint opened up at, I think, 8 o'clock or 9 o'clock. So, now, right. And we could give medications, you're going to learn in pharmacology, beta blockers are going to block the sympathetic nervous system. Yes, Henry?
Yes, ma'am.
Oh, right, I got it. Okay.
What can you differentiate what long-term versus short-term?
Okay, yeah. Well, the big thing is cortisol is going to just increase the blood sugar and increase metabolism, or just increase blood sugar. I'm sorry, not metabolism. Increase blood sugar, increase the use of protein and fats for energy, right? Where catecholamines are just going to increase our vital signs.
Okay. And then time period wise, is it depending on different people or? Okay.
Yeah. Now, chronic long-term, you're going to learn about acute and chronic. Chronic, sometimes the patient's vital signs will normalize if it's a chronic issue, but bless you. But this is a little bit more in the acute stage. She's having these acute migraines. So we're still releasing a little catecholamine. Good questions. Love them. All questions are good. Okay, so we're moving on to a new scenario. Let's recognize our clues here. But any questions so far? Good. Jean is a 28-year-old woman with chronic back pain. So after a motor vehicle collision, she suffered at the age of 22. So that's been 6 years ago, right? She is currently in the hospital in preparation for back surgery that is scheduled for the next day. All right. So she's had a car accident, chronic back pain. She's going to surgery. The nurse examines Jean and notices that she seems to have been experiencing colds more frequently since her motor vehicle crash, MVC. Considering the physiological effects of allostatic overload, chronic stress, the nurse knows that. You're correct. So the immune system may be suppressed. So long-term excessive cortisol secretion not only brings the blood sugar up, but it also long-term suppresses the immune system. So you don't have to raise your hand, but think about it. Has anybody, a loved one, had like bronchitis, especially during COVID, really bad bronchitis, and maybe needed to go on a steroid pack for a short period of time? Now steroids, glucocorticoids, cortisol, pretty much all the same thing, okay? They will decrease inflammation short term. That's why someone has severe bronchitis, inflammation in their bronchi. It'll reduce that inflammation and help them breathe, right? Now, long term, think about it. Short term, it suppresses the immune system. Long term, suppresses the immune system. So long term, they're gonna get sick more often. Because now they don't have that robust immune response to attack, any kind of microorganisms that come into their body. Does that make sense? Like long term, it's long term suppressing that inflammation or that immune response. Okay, so long term. All right. And in nursing school, you might find that you're the one that gets the colds, things like that. Sometimes it'll happen, yeah.
So you're saying if let's say they came in with like tonsillitis and you give them like a steroid shot, you're saying after the steroid shot for a certain time, their immune system will actually be suppressed and they're more likely to catch other illness?
Well, the steroid shot, because it's just one, it only lasts for 48 hours, but it's hopefully will reduce that inflammation in the tonsils so the person, will get better.
Yeah.
Short term, it's gonna be okay. It's just like this little boost. The cortisol increases and it reduces inflammation. It just blocks some of the inflammatory response in our body. Because when we get sick or we have a cut on our body, our inflammatory system kicks in. It's a good normal thing. But we have medications to reduce it to help us get better faster, right? And feel better. But that's okay. That's okay. That's not going to decrease their immune response. Now, if someone gets a cortisol shot in their knee or something, that's localized. That's different. It's not what we call systemic throughout the whole body. You're talking about a cortisol shot just one time, that's fine. That's short term. And people who go on a steroid pack, it's short term. They might just take it for 5-10 days, and actually the dosing goes down each day to kind of wean you off and get your body to wake up to the fact, okay, we got to start working again on the inflammatory response. Did I answer your question?
Yeah.
Okay. All right. So we have the same gene. The nurse notes that Gene's preoperative laboratory tests show a slightly elevated blood glucose level. This may be attributed to, give me your 1, 2, 3, 4. I think y'all got that, nailed that in there. Good. So let me tell you a clinical story. I worked in neurotrauma, saw a lot of young people who were in car accidents, head injuries. So they would have head injuries and they would be in a coma. And so I had this 22-year-old young man, healthy, no issues whatsoever. Healthy young man, no history of health issues. And his mom was at the bedside, he wasn't married. And I said, well, his blood sugar's up, so I'm gonna have to give him a little insulin shot. Insulin helps bring down blood sugar. And his mom goes, he's not diabetic. I said, absolutely, he's not. I said, but his body's under a lot of stress because he has a head injury, and I think he broke one of his legs as well. And I said, his body's under stress, so his body's trying to heal, and the response is increased blood sugar. When he gets better, his blood sugar should go back down to normal, and that'll be fine. I said, it's just a short-term thing. So I had to teach my family member about this scenario, and it helped her understand and oh, okay, it's just a short-term thing. So it's just a natural response. Yeah.
So even in the short term, like it still increase the blood glucose nothing.
Yeah, but he had been in the hospital for, usually head injuries and stuff like that takes a long time to heal. So a massive injury like that would take a long time to heal. So your body's under more chronic stress trying to heal. Yeah, exactly, yeah. So, absolutely. Other questions? All right. You might have your patient who maybe you work with someone who's got pneumonia and they don't have diabetes, but their blood sugar may be up because they're just sick. So, and you're gonna, when you get to diabetes, when you learn about diabetes, diabetics have to follow something called sick day rules, because when they get sick, their blood sugar goes up too.
Say that again, sorry.
When diabetics, especially diabetics who are type 1, you're gonna learn, I'm just putting this as a little, in your back pocket to think about. When diabetics get sick, they have to follow what's called sick day rules, because their blood sugar will go up as well when they're sick, just like everybody else's. But their blood sugar is already high. So when they get sick, their blood sugar is gonna go really high. So they've got certain, I'm not gonna go into it, you'll learn it later, but they've got certain rules they have to follow and do when they get sick. Like take more insulin, basically. So, all right. And that is it. So, that was just a review of chapter 7. Anything lingering, maybe when you watch chapter 7 that is just, you had a question about it or anything? Let's give you a minute to
Oh,
ponder.
yes, I have a question.
Yes.
So, when you talk about the other hormones that affect the best form react to your stress, in the PowerPoint you talked about prolactin. I don't know if I missed it, but all I got was rolling this month. What role does it play?
Prolactin will help a mother breastfeed after a baby. It does help with the during the stress of having a baby. It's a hormone that's secreted when a mother's in labor as well. Emily is over there nodding her head. So you're going to learn more about prolactin and oxytocin when you do mother-baby. It's stressful to have a baby. So but because of the baby and the placenta, those hormones are specifically secreted. Interesting, isn't it? And also oxytocin's the love hormone. When you fall in love, you feel like, ooh. So it also happens when you breastfeed too. And I think in the recording I talked about, I was like, oh, I felt a little like drunk. I was like, woo. I was like, let's keep breastfeeding. All right. So let us go on to chapter 8. But any other questions while I'm setting this up? Let me just set it up. Okay. Let me just look at the roster here. Elizabeth Fry here. Okay, you gotta make sure you sign the roster. So I'll just put here, but just sign it during the break. Shikaria, Johnson. Yeah, just make sure you sign the roster. Okay, all right. Just during the break. All right. So. Fluids and electrolytes. So here we go, chapter 8. Now here are the objectives. Again, use these as a study guide. Oh, in my eyes. So differentiate, when you see that word differentiate, you're comparing and contrasting. So you're going to pull a lot of your anatomy and physiology and like microbiology that you did pre-nursing. So intracellular versus extracellular. So what's intracellular? Where are we? Inside the cell. Good, good. We're going to learn more about that. Relate the concept of concentration gradient and the process of diffusion and osmosis. We kind of reviewed that a little bit on day 1, diffusion and osmosis. We're going to dive into it a little bit more. See how things build? Things build in this class. So cell volume, isotonic, hypotonic, hypertonic. And then I'm going to be doing this lecture in farm. but then we're gonna talk about IV fluids in farm. So, so again, you're gonna take this class with you. Body water levels, salt concentration, sympathetic nervous system, the renin-angiotensin-aldosterone system, antidiuretic hormone, we're gonna learn all about that. And then we're gonna get into antidiuretic again, aquaporins, we already talked about aquaporins on Monday. Potassium, and then the hypokalemia, hyperkalemia. Now kalemia means potassium. Hypo means what? High or low? Low. Hyper means high. Good. And then we're going to talk about vitamin D and absorption of our calcium, phosphorus, and magnesium levels. And then we're going to talk about hydrostatic pressure in our capillaries and colloidal osmotic pressure, interstitial fluid pressure, etc. So now, continue learning objectives. So again, use these as your study guide. What causes edema? Now remember I said edema was swelling. And there's something called third spacing. Anasarca. Does anybody know what anasarca means? Full body edema, like the whole body is just swollen. Full. If you say, oh, that patient has anasarca, that means they just look like the Michelin Man. They're all swollen. Now there's something called dependent edema. When you hear the word dependent, it means someone is dangling their feet usually, and that foot, that leg is dependent. So they get edema by their feet just dangling. Like y'all, I go to the grocery store and anywhere, and I'm checking people out. I was standing in line at the pharmacy, and I was 6 feet away trying to give this woman some privacy. And she was talking to the pharmacist, talking about her diuretics, and she goes, my left foot is swollen. And I'm like, trying to look at her left foot. And I heard the pharmacist talk to her, and the pharmacist was saying everything that I thought as well. But, you know, I'm always checking people out. I'm assessing, not judging. Assessing. So we're going to talk about aquaporins, which we already kind of mentioned on last Monday. So, then we're going to do acid-base. Acid-base. And that is, have anybody heard about ABGs, arterial blood gases? We're going to learn, it's a blood test that in the state of Georgia, respiratory therapists, nurse anesthetists, and physicians can take from the arteries. They usually go from the radial artery, the brachial, or the femoral, and it's arterial blood versus venous blood. So when you just go get your blood work drawn in your little antecubital space here in your elbow, that's just venous blood, right? But this is arterial blood. So what do you think is going to be the difference? What's going to be higher in the arterial blood? Oxygen. Yeah, oxygen. So we're going to learn about our pH balance. So that's, you know, is our body, do you guys remember the acid base, like 7.35 and anatomy maybe? Acidosis, alkalosis, absolutely. So we're going to learn about some disease processes with that. So there's something called metabolic acidosis and alkalosis and respiratory acidosis and alkalosis. So we're going to talk about those two disorders. Okay, so let's just look at our ions. The ones that I really need you to know are your sodium, which is Na. So this is your periodic table. We've got to bring chemistry in. K is potassium. Ca is what? Calcium. Mg. And H is hydrogen. This is bicarb, and that's chloride. But they're either positive or negative. Now that's all I need you to know. That's it. Because if you remember those channel proteins that we learned about, the things that go in and out of the cell, so, you know, if the cell's too negative, the positive ions will go in to balance it out. So it's just those channel proteins are controlled by the negativity or the positivity of the electrolytes and other elements. And then we have non-electrolytes. We've got glucose and urea, and they don't really dissociate or dissolve in our or bind with other things in the body. So, because we have urea in our urine, right? And we also have urea can build up in our joints and cause your gout. And that's just a little side note. But okay. So functions of the body fluid. So these gases and nutrients They can get transported. They help generate electrical activity needed to power our body. So potassium and calcium and magnesium have a lot to do with just being able to move, right? Our skeletal muscle and our heart muscle. Can I control my heart muscle? No, it's what we call smooth muscle, right? And so if our calcium, if our potassium or magnesium are off, we can have heart rhythm dysrhythmias or irregular heartbeats. Part of number 3, take part in the transformation of food into energy, and 4, maintain overall function of the body. So we need our electrolytes to be within normal range for us to properly function. If we don't, we start feeling the effects of those abnormal electrolytes. Now, let's get into our cells. So we have inside the cell, so we have the cell, right? So we've got the cell, so that's intracellular, right? Inside the cell. And larger of the 2 compartments in the body, and inside the cell is our potassium. We have a lot of potassium inside our cell, right? And then we've got the extracellular. So we've got our extracellular is our blood vessel. So that's going to be our extracellular fluid, or ECF. So we got our blood vessel, and we also have, or what we call the, this is called the vascular space. The vascular space, and that's extracellular. And the intracellular is intracellular fluid. Right? What is another space that's extracellular? That other space that's extracellular. This purple here. It's S-T-I-T. I don't spell very well. I think that's interstitial, is also extracellular fluid. So the interstitial is the in-between space. So in between the cell and the blood vessel. So the interstitial is the space between the cell and the blood vessel. So this purple area is interstitial. So those are our 3 spaces. Well, let me say this. We have 2 spaces. We have intracellular, and the second space is called extracellular. But the extracellular's got 2 spaces within it, the interstitial and the vascular. The extracellular has 2 spaces within it, the interstitial and the vascular. Any questions on that so far? Now, our extracellular fluid is high in sodium. Our extracellular fluid is high in sodium. Our intracellular is high in potassium. It's just the way the normal body is. Okay? All right. Now here is a better picture. Well, my drawing. So again, we have our intracellular. And then isn't a red blood cell a cell? But doesn't that float in the bloodstream? But it's a cell, so it's a cell. And rich in potassium. It does have magnesium, proteins, inorganic and organic phosphates, low in sodium and chloride. But the extracellular, like I said, vascular, interstitial, and we always also have transcellular as part of the extracellular. And the transcellular is like your cerebral spinal fluid, your synovial fluid in your joints, but I'm not going to talk about the transcellular. But it's like cerebral spinal fluid and the fluid between your joints, etc. Again, rich in sodium, low in potassium, mag, and phosphate. So you could see, the interstitial space, and you could see the cellular space. So think extracellular is your plasma, or your vascular is your plasma, like your blood. The interstitial contains a lot of water. And so does your cell. Your cells contains a lot of water as well. All right. Now composition of the extracellular fluid, plasma, and interstitial fluid, so large amounts of sodium and chloride, moderate amounts of bicarb, and then small quantities of potassium, mag, and calcium, which is just redundant. This is kind of a redundant slide. Okay. So composition of intracellular, almost no calcium inside the cell. Because what do you guys remember last week I said, what happens if too much calcium goes in the cell will, we'll start dying, right? Necrosis. Small amounts of sodium chloride, bicarbon, phosphate, moderate amounts of mag, and large amount of potassium in that cell. So this is just reviewing again, redundant. Now here's a question, give me your 1, 2, 3, 4 fingers. Which ion is the highest concentration inside the cell? Yeah, it's gonna be potassium. Now what do you think happens when our cells die? Where does the potassium go? Yeah, outside of our cell into our interstitial and our bloodstream. So when we have cell lysis means cell breaking from cell death, from necrosis, we could have high potassium. When people, when their hearts stop and we have something called a code blue in the hospital means their heart has stopped and they stop breathing and we have to do CPR, they're going to have a high potassium. They will have a high potassium because cells were dying because they weren't getting the circulation to their brain, their heart, their organs, right? Yeah.
So is the potassium then eaten by like the white blood cells with the phagocytosis, or is it more like
No,
divided into
the white blood cells are not going to really react to the potassium. The kidneys are going to try to expel it. And when you can write this down. When there is high potassium, there is acidosis. When there is hyperkalemia, there is acidosis. So there's a whole other pathophysiology going on there too. When there is high potassium, there is metabolic acidosis. There is acidosis. And the reason for that is the potassium and the hydrogen ions are changing places in the cell. So we'll talk about that later. More about that later. But there's a lot going on when you talk about the electrolytes. Okay. Now let's talk about osmosis and diffusion. We already said osmosis is what following what? Water follows salt. So the difference in the gradient. So we already kind of looked at if we have too much sodium in our bloodstream, where is the water going to go? It's going to go out of the cell, and so then our cell, what will happen to our cell? It'll shrink. The cell will shrink. If the sodium is too high in the bloodstream, so we call that hypernatremia. The word emia means blood. So the sodium is high in the bloodstream, so you have to remember that. The sodium is high in the bloodstream because when we draw our blood, that's where we're seeing if there's hypernatremia, high sodium, that's where we're seeing it in the bloodstream, right? We can't measure what's in the cell unless we do a biopsy, right? So the only thing we can really measure is what is the electrolyte doing, or how much electrolyte is in the blood. And that if the sodium's really high, we know the cells are shrinking. But more about that later, because that is osmosis, right? What if it's the opposite? What if we have the cell, we've got the bloodstream, and we've got too much sodium inside the cell? What's going to happen to the water?
It's gonna go into the cell.
The water's going to go to the cell, and what is the cell going to do? Expand. And so when we've got, if we have low sodium, if we have Hyponatremia, that means low sodium in the blood. So that means the cells are going to expand. So if you've got low sodium, you need to know your cells, especially in the brain, are expanding. If they have high sodium in the bloodstream, you need to know their cells are shrinking, especially in the brain. The brain cells are shrinking. And let me tell you, the brain does not like either of that. The brain doesn't like swollen cells. The brain doesn't like shrunk cells. So we're going to have neurological issues. Patient's going to have decreased level of consciousness. They can be confused, restless. And if it's severe, they can have seizures because, seizures are part of the brain. Electrical activity is too abundant. So that is osmosis, and I pretty much just taught you the pathogenesis of hyper and hyponatremia. This is the pathogenesis of hypo and hypernatremia. The cells will shrink if we have hypernatremia, and the cells will expand if we have hyponatremia. That's the pathogenesis. That's what's the detailed thing that's happening inside the body with this disease process. So that's the pathogenesis. So diffusion is like our something going, a solute going across a membrane. So like our oxygen and carbon dioxide in our lungs. Just shoop, shoop, they just go in and out of the alveoli. So, let's see, where's my clicker? All right. Okay, so here's osmosis and diffusion. Anybody see my clicker? It's on the board over here.
Next to
Oh,
the
thank you. I gotta make it orange so I can see it, right? All right, it's just osmosis is the fluid goes through a semi-permeable membrane, so that would be the cell membrane, right? To dilute all those solutes there. So to dilute all the solutes. Where diffusion is the solute, let's say oxygen, goes through the semi-permeable membrane to balance out those solutes or oxygen or CO2 or whatever. So that's the difference between diffusion and osmosis. Questions on that? Okay. That's kind of review of at A&P and your microbiology. Okay. Now this we're going to take with us to farm. You might even see the same slide again. So, now we already said if we have hyponatremia, it means the fluid is hypotonic. So that means our blood is hypotonic. So the cell is going to expand. It could even rupture if we don't stop this process. Okay. Now we're going to learn about hypotonic IV fluids because IV means intravascular. So we're giving that fluid in this bloodstream here, right? So the electrolytes that are in that IV bag are going to interact with our cells, with our body. And sometimes we give these fluids when a patient has a diabetes crisis called diabetic ketoacidosis. We might give them hypotonic fluid because their cells are dehydrated to rehydrate their cell. There's reasons for giving these fluids. Okay? Now, isotonic, what does that mean? The IV fluid, the fluid inside the bloodstream is balanced. So the cells are going to neither shrink or expand. They're going to stay the same. And you notice these are red blood cells because those are the ones that are floating in the bloodstream, right? So they're going to be the most affected by our IV fluids. Now the brain seems to be most affected by the sodium level as well. So this IV fluid is going to have a normal level of sodium. The hypotonic is going to have a low level of sodium in it. The hypertonic is going to have a high level of sodium in it, or it can have dextrose in it as well. And that's going to be a hypertonic fluid, which means it's got a high percentage of sodium or other solutes, and it's going to make those cells shrink. We would give hypertonic IV fluids to someone who has cerebral edema, brain edema from a stroke, a head injury. So there's reasons why we give these different types of fluids, but just keep the hypertonic, hypotonic, isotonic, And I think it's in a week or so, I teach the farm on this, okay? All right, questions? Is it all flowing? Is it, okay. If you feel like you need to talk to me at break, I'll be happy to. Okay, now. Okay, yeah, we got a few more minutes. Let's talk about this. How do fluids, we already talked about the osmosis. We already talked about how fluids move in and out of the cell. So the fluids move in and out of the cell because of what electrolyte? Sodium. Fluids move in and out of the cell because of osmosis. Water follows salt. So if we have too much sodium inside the cell, then the water is going to go into the cell, right? If we have too much too much sodium in the bloodstream, the water is going to float into the bloodstream. So osmotic pressure, intracellular fluid shifting is osmosis because of sodium. Intracellular fluid shifting is osmosis because of sodium. Remember those little aquaporins that just let the water in and out? That's how fluids go in and out of the cell. Now let's talk about how do fluids go in and out of the blood to the interstitial space. How do fluids move? Now fluids move from that space to this space. I wish I could write on here. Nope, okay. I'm gonna have to, are we okay to erase this? Does anybody want to take a picture of it? You want to take a picture of it? While she's taking that picture, fluids move in and out of the vascular space and the interstitial space because of proteins. Okay, so let's just draw this picture again. But we're gonna do proteins. Well, I don't know if I have to use the picture. Let's use this. So,
Wait, you said,
Yeah.
fluids move out of the intracellular because of proteins?
fluids will, no, not cells. Fluids will move from the vascular space to the interstitial space because of proteins. So we're talking now the extracellular compartment. We're done with the cells. We're in the extracellular compartment. So which is vascular and interstitial, right? Those are the two parts of the extracellular compartment. So, okay. So the cellular was the sodium. That's osmosis, sodium, cells, how things get in, how water moves in and out of the cell. Now we're going to talk about how water moves in and out of the bloodstream and the interstitial space. So we're in the extracellular space. So if in our bloodstream, the vascular compartment, we've got a lot of protein, that means it's capillary colloid osmotic pressure. Now there's osmosis, but the word colloid means protein. The protein is doing the osmotic pooling. So these little blobs here are proteins. Let's just say they're the protein. They're really big. So if we have a lot of protein colloid, we have a lot of colloids or proteins in our blood vessel, the water is going to go into the blood vessel from the interstitial space. Interstitial space to the to the blood vessel if we have too many proteins. So that's increased capillary colloid osmotic pressure. Now the osmosis is colloid protein. And the colloid actually is albumin. So the substance is albumin. Now, if we don't have enough, let's see, here is it. If we don't have enough protein in our bloodstream, if we don't have enough albumin in our bloodstream, like people with liver disease don't have enough albumin in their bloodstream, then the water will go into the interstitial space. So that's called increased interstitial colloid osmotic pressure. So the water can flow either way depending on where the protein is. The water can flow either way depending on where the protein is. So if the protein is in the interstitial space, then the water's gonna flow into the interstitial space. So people with liver failure, they don't make enough albumin, they'll get something called this big Buddha belly. That's called ascites. So that's a part of liver failure. They get this edema in their abdomen. So interstitial fluid increase is edema. We just call it different things. Okay? So colloid osmotic pressure is all about what substance?
Protein.
Protein doing that osmotic pull. The colloid protein is doing that osmotic pull. So that's protein doing the pulling. Protein's doing the pulling. Wherever the protein is, the water goes. Whether the interstitial space or the capillary space. Any questions so far? Yeah.
Can you have the water being pulled by the proteins and the sodium at the same time?
Sodium is only gonna pull in the cell.
Yeah.
Yeah.
So
It can if you've got a sodium imbalance with a protein imbalance.
so
So
the
you-
water just doesn't know where to go, or
Yeah, well, the water, it depends on what kind of sodium imbalance you have.
okay.
So if it's low sodium, the water's gonna go into,
The extracellular.
yeah, exactly. So it depends on what disorder. So sodium's always cellular, sodium cellular. Protein is gonna be the extracellular. So it's gonna be too much protein in the vascular space, it's gonna cause fluid volume overload in the vascular space. And too much protein in the interstitial space is gonna cause edema. So too much protein in the interstitial space can cause edema. An example of that is liver failure, the ascites, the big Buddha belly. People, alcoholics, people have hepatitis, stuff like that. So let's do one more flow of fluid, one more type of flow of fluid, then we'll take a break. Yeah, oh yeah, what's your name again? V, yes.
I'm going to go to the restroom.
Yeah, you guys wanna take a quick break? Yeah. So why don't we take a break and then